as surgeons and neurologists and so on. And mostly we just talk to each other. And I think the ASAP meeting is really important because it's a great opportunity for us to not just talk to each other like we always do, but to actually interact with a lot of patients all at one time to see what the concerns are in the Chiari patient community. So thanks to Patrice and Patricia and everybody else at ASAP for organizing this year. I know there were a lot of challenges with having to go virtual, but I want to congratulate you so far on having a really excellent meeting this year. So I thought I'd talk today briefly about an issue that I do think is very important and I hope will be of interest to many of you, and that's Chiari and pregnancy. What to do when you have a Chiari, either treated or untreated, and you find out you're pregnant. Should the pregnancy be treated in any way differently than any other woman with a pregnancy? I should say I have no conflict of interest in any material or device that I'm discussing today. So pregnancy, obviously, for most people is a very happy time. But again, when you have a Chiari malformation, it's hard to know, is this going to be okay? Is this going to make my Chiari malformation worse? Do I have my own health concerns? Are there health concerns for the baby? And so on. And I'm going to share some data with you today that I hope will make some of you reconsider that and see that actually the data right now doesn't support any very high level of concern for most patients. I'd like to start by just discussing what we know about Chiari malformation and pregnancy prior to the work that I'm going to talk about today. And it was mostly on the level of case reports, that is to say individual patients that have been discussed in the medical literature, or small case series, that is to say a few patients at a time that have been discussed in the medical literature. And when we consider levels of medical evidence, that's really the worst level of medical evidence, because we know that there can be exceptions, and we try not to base our practice off rare exceptions. We try to base our practice off what's going to happen with most people and make decisions that make sense for most people, taking then individual variations into account as best as we can. So here's some examples of case reports, individual patients that have been written up in the medical literature in the past several years. And these are both in the anesthesia literature. And essentially these case reports say, I had a woman with a Chiari that I was taking care of who delivered a baby, and we did a anesthetic and everything worked out okay. Now, for many of us that see a lot of Chiari patients, that probably doesn't strike us as extremely reportable. That is to say, it doesn't strike us as something that is surprising. We know presumably lots of women with Chiari malformation that have had babies without any difficulty, but so little has been described in the actual medical literature that in several cases, journals are still publishing examples of even a single patient with Chiari that has had a baby successfully. There have been a few examples of case series, that is to say not just one patient, but several patients put together that have been reported in the literature. And this is considered a better level of evidence. I know many of you attending today will know Dr. Oro, who's a friend to many of us, and he published this article a few years ago where he described 7 patients with Chiari malformation, 4 of whom had epidural anesthetics, and essentially people did well. There were no serious problems with any of these 7 patients. So again, I think a nice paper, not very surprising for those of us that see a lot of Chiari patients, but again, so little is known about Chiari and pregnancy in the literature that this was considered important to write about. Here is a slightly larger case series of 12 patients. This is from the Mayo Clinic back from 2002. And again, this is very similar. 12 patients had 30 babies, and they had 6, half of the patients had epidurals. There was 1 spinal anesthetic. And again, none of the patients had any serious medical problems with their pregnancies or their deliveries. So you're sensing a theme. We're seeing not a lot of problems with Chiari patients having babies, and yet we're writing about it because there's a lot of concern, I think, out there in the community that this can be a problem. So those are the case series and the case reports that are in the medical literature already. This just came out. This is another article that just came out last month in the Journal of Clinical Neuroscience. And it has this very exciting title, I think, Determinants of Chiari-1 Progression in Pregnancy. And I saw the title and I thought, well, this is great. This will be an interesting paper talking about risk factors for Chiari patients having babies, what's safe, what's at risk, and so on. And in fact, unfortunately, when you get into this paper and read it in detail, they do not describe any Chiari patients having babies. They simply state what I've already told you, which is that we know a little bit about it based on some case series and case reports in the literature. They don't provide any new information on their own. Nevertheless, although they present no new information, they do present this algorithm, which you can see on the right side of the screen that we're projecting. And this algorithm suggests for practitioners how we should manage pregnant patients with Chiari malformation. And you can see that essentially everybody's getting an OBGYN evaluation. And they are making some suggestions, such as avoiding Valsalva and pushing efforts being preferred, such as in some cases avoiding epidural, having to practice epidural anesthetics with great caution. So again, no actual data, no information, but they're making these suggestions. There are other examples that I could show you as well, but time doesn't permit, that essentially say the same thing without presenting any actual data saying, well, maybe we should be really careful here. So that's an opinion, and everybody can have their opinion, but we really, if we're going to have a enlightened and correct opinion, we really should try as hard as we can to get data. And right now we don't have a lot of data on this. So I have tried to correct that a little bit. We've been working with a database called the Optum Database over the past several years. And I've written a number of articles based on this database. I've never looked before at pregnancy issues using this database, but I thought it would be a good database to use to address this question just because of the very large numbers that are involved. Any of us in our practices, even if we have very, very busy Chiari practices, are not going to know 1,000 women with a Chiari and pregnancy. And this is a database that allows you to do that. Every year, this database has millions and millions of patients. You can see in the right-hand column the number of patients included in the data set every year. So overall in the data set, if you do a study from 01 to 14, you're going to get over 50 million unique patients that have been in the data set for at least 5 years. And any given year, especially recently, you have between 25 and 30 million patients per year. So that's a lot of patients to study. In terms of patients that are getting a Chiari diagnosis in each of these discrete years, you can see the numbers there for yourself. But the numbers are quite large, with over 5,000 per year towards the end of the data set. So we looked at that data set again, 58 million patients to enter into the data set. And then we started to analyze the data set according to what's known as ICD codes or diagnosis codes. So we looked at everyone with a Chiari diagnosis code, which is 348.4, and found almost 35,000 patients with that diagnosis code. We deliberately excluded patients with Chiari-2 malformation. We were most interested in talking about Chiari-1 malformation. Chiari-2 would be an interesting topic, I think, in its own right, but that was not what we were looking at for the purpose of this analysis. So again, we excluded Chiari-2 patients by excluding everybody with a myelomeningocele diagnosis. We were left with 33,000 Chiari patients to study. Of those 33,000 Chiari patients, slightly over 1,000 hospital admissions for childbirth that we were able to analyze. More than half of them were diagnosed, were delivered prior to the Chiari diagnosis, and slightly under half were diagnosed after the Chiari diagnosis. So those are the Chiari patients that we were able to study, 1,048 childbirths in Chiari patients. In addition to that, because we wanted a comparison group of patients without Chiari, we studied 1,000 patients for each year of our study, which was 11 years. So we had 11,000 patients with no Chiari. And we wanted to compare the mortality rate, morbidity rate, who had trouble with their pregnancies, for the pregnancies, the cesareans, the rate of epidural anesthetic. And here's some bottom line information for the Chiari group. Again, 1,048 overall Chiari patients, 400 patients died with delivery after Chiari, 648 with delivery before the Chiari diagnosis. And whether you were delivered before or after, the average age was about 30 years of age. Whether you were diagnosed before or after, the average length of hospital stay was about 2.7 days. The cesarean section rate in Chiari patients was 38.5%. Epidural rate, you can see there, and the syrinx rate was relatively low. Some of you may be surprised at the very low rate of syringomyelia in this group. And I think that's important to point out that this is a group of all Chiari patients, not just surgical Chiari patients, which you would expect the syrinx rate to be much lower. Looking at the year-by-year analysis of who had a Chiari malformation with a delivery, you can see that the rate has been increasing over time. It goes up and down, oscillates randomly, I think, year by year, but in general, the trend has been up. And this is not surprising. This is a trend that you can see with Chiari almost no matter how you look at Chiari, because Chiari is more commonly diagnosed now than it was in the early years of our data set. Here's a paper we wrote a few years ago looking at Chiari diagnosis and surgery in the United States, again using the same Optum data set. And you can see that in the early days of the study, 2001, compared to later on, especially in children, the rate of Chiari surgery has almost doubled in that time. Similarly, looking at Chiari diagnosis over the same time, 2001 to 2014, you can see that the rate of Chiari diagnosis in our data set has more than doubled in that time. So Chiari is becoming a more common diagnosis. Chiari surgery is becoming more common. And so therefore, I think delivering babies with Chiari is also becoming more common in that time. We were interested in seeing if having the diagnosis of Chiari changes medical recommendations for women who are having babies. And the answer seems to be yes, as I'll show you. When we look at the rate of cesarean section in women with Chiari, we found that women with Chiari were definitely more likely to have a cesarean section than women without Chiari. There was something called an odds ratio of 1.42, and what that means is if you have a Chiari on average, you have 1.42 cesarean sections versus a woman without a Chiari, who would be at 1. So that's a very significant difference. And even with the 95% confidence interval, you can see that the confidence intervals are all over 1 as well, meaning that we can be quite certain that women with Chiari are actually at increased risk, if you can call it risk, of having cesarean sections versus women without Chiari. The other thing I want to point out is this does not seem to be uniform over time. In fact, the trend seems to be accelerating. If you look at the early years of our data set, it's a little bit of a mixed bag with the Chiari patients in red here and the control or non-Chiari patients in blue. You can see that there's a lot of overlap. The lines are crossing. Chiari patients in the first half of our study in fact, didn't seem to be more likely to have cesarean sections than non-Chiari patients. But now, I think as a result of medical recommendations that are being made, perhaps as a result of more awareness of Chiari malformation, you can see that the lines are no longer crossing back and forth against one another. You can see that those with Chiari in red are year after year after year significantly more likely to have a cesarean section than those without Chiari. So if we go back and just look at this time period, 2009 to 2014, the odds ratio would even be significantly higher than 1.4. The other question we had is, do patients with Chiari, are they more likely to have a recommendation against having an epidural? There is some concern, if you read the literature, some authors have postulated that we should avoid epidural anesthetics in patients with Chiari because of the risk of spinal fluid leak. And if we get a lot of leaking spinal fluid, we can exacerbate a Chiari. I will acknowledge that that's a very reasonable theoretical concern. What hasn't been answered is the cost of avoiding the right anesthetic treatment for these women worth the theoretical benefit of avoiding an epidural anesthetic, and how many women are actually avoiding an epidural anesthetic with a Chiari. And the answer seems to be a lot. A lot of women with Chiari are avoiding an epidural anesthetic, perhaps as a result of medical recommendations that are being made to them. And here again, you can see the Chiari patients in red and the non-Chiari patients in blue. When we look at them year upon year upon year, in general, with the exception of 1 year, which I can't explain, but that's the outlier, Chiari patients are definitely less likely to have an epidural anesthetic than patients without Chiari. In fact, a very significant odds ratio, again, 0.67. That means that for every one person without a Chiari that has an epidural anesthetic, for the same number of people, only 2/3 of that group would have an epidural anesthetic in the Chiari group. So a very significant difference. And again, just like I showed you that the rate of cesarean section in Chiari patients is increasing, the rate of epidural anesthesia in Chiari patients seems to be decreasing. When we focus only on the more recent years, 2009 on up, we can see that the gap seems to be wider and widening over time. So again, Chiari patients in red and non-Chiari patients in blue, and much higher rates of epidural anesthetics among non-Chiari patients. So I think we have to ask ourselves why that is, and I suspect that a very great reason for it is that when the diagnosis of Chiari becomes known, anesthesiologists and obstetricians are recommending against epidural anesthesia in many cases. So what about problems with childbirth and delivery? Delivery-associated morbidity when patients have a Chiari malformation. So we decided to look at this in some detail, and fortunately there's a good precedent in the obstetrics medical literature for how to analyze morbidity in pregnant women. They have a systematic approach of doing this, and many obstetrical papers will study certain things to decide if something is causing problems during childbirth and delivery. And they study all of the things that I've listed here in this table. You can see at the top, renal failure, liver failure, respiratory failure, obstetric shock, and so on down the list. And then also procedures that are needed, hysterectomies, transfusion, needing blood after delivery, and so on. Are you discharged after your delivery to home or somewhere else? And also, what is your length of stay? How long are you staying in the hospital after delivery? So we studied all the Chiari patients with respect to all of these comorbidity codes. We studied them as a group together, as well as whether or not the diagnosis of Chiari was either known or unknown, whether the diagnosis was made before or after delivery. And the first thing I'll point out is that the overall rate of morbidity or having a problem with childbirth was 1% in our Chiari group. 10 total patients had an associated morbidity coded. That didn't seem to be different whether the diagnosis of Chiari was known or unknown prior to the delivery. And the individual morbidities that were experienced were sort of spread out all over the map. There was one person who had a renal failure, two people who had respiratory failure, 2 people who had a cerebrovascular accident, 1 person who had eclampsia, 6 patients who required a transfusion. So that's the maternal morbidity that was seen in 1,048 Chiari patients. So the question, though, should not be, can a patient with a Chiari experience any maternal morbidity? Because we know any woman can experience some maternal morbidity. So the question has to become, is there something about the Chiari that we need to treat differently? because is a patient with a Chiari malformation at more risk than somebody without Chiari malformation for experiencing maternal morbidity? So in order to answer that question, we compared this group to the group of 11,000 women that were selected out of our data set that did not have Chiari malformation. And here's what we found. Again, in the Chiari group, the overall morbidity was 1%. Actually, the rate of overall morbidity was a little bit higher in patients that didn't have Chiari malformation. That was not a statistically important difference. So we can do a test to see if this is a real difference that we can reliably say we could find no matter how many times we study it, or if this is just a slightly higher rate that doesn't statistically matter. And that's what we found, that there was no statistically important difference between Chiari patients and those that did not have Chiari. Both sets had a rate of morbidity or a problem with their childbirth of about 1%. Looking at it out of a rate of 10,000 women having babies, which is how many people like to cite these data. This is how the American College of Obstetricians and Gynecologists cites the data. We found that patients with Chiari had 95 per 10,000 morbidity events, whereas if you didn't have a Chiari, again, 137 over 10,000 morbidity events, not statistically different. We did ask ourselves the question, well, what if our 11,000 patients that don't have Chiari just have a disproportionately high rate of morbidity? That doesn't seem to be the case. There are a lot of examples in the obstetrical literature that have studied maternal morbidity using the same methods in non-Chiari patients. And here's one good recent example, Callahan and others from 2012, which is right in the middle of the time period that we studied. And they found something very similar, 129 morbidity events per 10,000 patients. So again, not different than the Chiari group. I think we can say safely that patients with Chiari malformation do not seem to be experiencing increased maternal morbidity in general compared to patients that don't have Chiari malformation. So I'd offer this as a conclusion. We can see, I think, clearly that women with Chiari malformation are more likely to have cesarean sections than those without Chiari malformation, and are also less likely to have an epidural anesthetic. Epidurals are the favorite anesthetic for most pregnant women, and I do believe that there's evidence here to suggest that women with Chiari malformation, when the diagnosis is known, are being recommended to have other forms of anesthetic, mostly general anesthesia or no anesthesia. And I would argue that there's not a great deal of evidence right now for that practice, and also not a great deal of evidence for recommending prophylactic C-sections versus normal vaginal births. Furthermore, these trends seem to be increasing over time. Again, without evidence for any effectiveness, these recommendations seem to be taking off, and year upon year are actually being practiced with increasing frequency. In fact, what our data would support, though, is that there are low rates of maternal morbidity with patients with Chiari malformation that are having babies. There's no evidence of substantially increased maternal risk. So I think, in general, for most patients, we go back to this modified monk painting, not the scream, but the happy monk. For most patients with Chiari, when I see them and they're pregnant, I'm able to offer them reassurance and say that this is something that you should listen to your obstetrician's advice about the delivery and the anesthetic, but not necessarily take the Chiari into account. I will make exceptions for that, though. Here's an example of a more severe Chiari with a very severe cervical syrinx. And this is somebody that I might counsel differently. I might tell them to be careful with for instance, a natural childbirth with a lot of pushing and that sort of thing. So I think every patient is different, but again, for most patients, this is not a typical patient. This is a typical patient. And for most patients with Chiari, I think we can offer them relatively reassuring data now that the childbirth will be safe. So with that, I'll end my slideshow. And again, I want to thank the organizers of ASAP for putting on this great conference for us today. Thank you very much.